First of all, I would like to thank Nestle Nutrition Institute to organizing this scientific webinar and for the invitation given to me being the resource person. So I thought just selecting a timely topic for y'all, the new registrars, because I think the global initiative of asthma, and every year they are updating their guidelines. So it's quite hard for us to understand. Sometimes changes are happening real dramatically. And so now over the last 2-3 years, there had been so many changes they have put on to these GINA guidelines, especially when it comes to adult asthma. And even some of these changes have been done even to the adolescents and the childhood asthma as well. So my topic today is preschool wheezing versus childhood asthma. Asthma is the most common chronic non-communicable disease. It's a common chronic disorder of the airway resulting in recurrent attacks of breathlessness, generally accompanied by wheezing, chest tightness, cough, which varies in severity over time. Now, this is usually the definition given everywhere, even the GINA, even the American, even the European Respiratory Society, and they all just giving this kind of a similar the definition for asthma. And I think it is nothing new for the registrars who are in this audience today. I would like to just give you a few topics before I move over to my topic of GINA perspectives and the new changes, what they have done. I just want to touch you a bit of a new things, which is actually developing and really interesting things just to talk about the related to the background knowledge of asthma. What is atopic march? Atopic march, now you may have seen a lot of pediatric patients, those who comes with like a food allergy or an atopic dermatitis, and they usually grow out of their disease by the age of 2-3 years, and then they get the childhood asthma, and the childhood asthma is also coming into a peak like the school going age, and then again it comes over to a plateau by about adolescence. But this allergic rhinitis, then it starts this allergic rhinitis like around 5 or 10 years of age. Then it goes on to a very, very peak level, and then it will stay there until their 40s or 50s or maybe till they die. Right? So hopefully not within the same severity, but with less severity, or even some people would experience with the same severity. So this part you call the allergic march or atopic march. Now it's a nice, I can explain you usually the myths and taboos that prevail in the society, what the people believe, and if you cure allergic rhinitis, දදයක් හොඳ කරෝතින් දදය හැරෙනවා හතියට. So that was the common belief among our people in the society, the lay people. They thought they should not treat the atopic dermatitis. It should be there because if you heal this atopic dermatitis later on, it will move over to asthma. So that is not the true story. Now atopic march, allergic march nicely explained, and this kind of a moving from one clinical entity to over to the other. Now this schematic diagram shows you how the people would get allergy, right? Now here you can see allergen that comes to your antigen presenting cells, and these antigen presenting cells gives these antigen processing, and with the major histocompatibility complex class 2, and it gives it to the T helper cells. TH0 means this is undifferentiated T helper. You call it a naive, N-A-I-E-V-E, naive T cell. That is because it is undifferentiated. It is the first time they get the presentation, or just the antigen presenting cells gives the antigen over to this naive TH cells, T helper. Now what will happen? Either it will move over to the TH1 pathway or a TH2 pathway is quite interesting. That is genetically determined. But Environmental factors can modify this genetic determination, but basically it is genetically determined. All right. Now, when there are interleukin 12, this moves over to Th1 pathway, and that is a good pathway, like a non-allergic pathway, gamma interferon, and then they hopefully remove this antigen. But if it moves over to Th2 pathway in the presence of interleukin 4, what will happen? This Th2 then moves to eosinophils in the presence of interleukin 5, and they attract a lot of eosinophils over to the site. And in the presence of interleukin 4 and interleukin 13, these T helper cells give the signal to B. Usually the B lymphocytes are the ones that produce IgG and IgM immunoglobulin. That gives a very beneficial effect to kill the microbes or giving the protection from the disorders. But instead of just giving the IgG or IgM, these T helper 2 cells give the signals to B. You do the class switching. You just gives off IgE instead of IgM and the IgG. So you call this process is a class switching. So with this you form immunoglobulin E. So this immunoglobulin E attached to mast cells, and then when the next antigen comes over and like a subsequent exposure to the same antigen, the same individual, now you know the process, degranulation and the liberation of lot of chemicals, histamine, tryptase, and all these, like what really requires for our immune reactions and allergy reactions are just given by these mast cells degranulation. So this Th1, Th2 that determines our future outcome, whether we are moving over to allergy pathway or whether we are moving over to non-allergy pathway. So hygiene hypothesis, that's why I told you, though these in allergy or immunology pathways are genetically determined, environment can modify our genetically predispositions to allergy. So the hygiene hypothesis nicely explained that the increase in asthma is due to decreased exposure to infections in early life. Frequent infections generate Th1 cytokines, interleukin 12, interleukin 18, and gamma interferon. Th1 is the best pathway, not the Th2. Now, hygiene hypothesis, again nicely explained. From birth, either it goes over to Th1 no allergy or Th2 allergy. How does it comes here? Now, how this from birth it move over to Th1 is whether there are multiple siblings in the family, so many infections in the environment. You go to early daycare and expose a lot of infection, and rural environment, got exposure to livestock and childhood infections, microbial exposure, and that moves over to no allergies. So in contrast, how does it move over to allergy pathway? Only child, widespread use of antibiotic, urban environment, sanitizer usage, cleanliness, and lot of other cleaning procedures, and allergen sensitization like exposure to dust mite and cockroaches excreta. So these are the risk factors that moves our pathway over to Th2. And see that again the similar the representation here. And developing countries, large family size, rural homes, livestock, intestinal microflora variable and transient, low antibiotic use, high helminthic burden, poor sanitation, high orophycal burden, non-allergy. In contrast to westernized country, small family size, affluent urban home, intestinal microflora stable, high antibiotic use, low or absent helminth burden, good sanitation, low orophycal burden, moves over to allergic disorder. Now, where are we now in Sri Lanka? Now, being a developing country, but is this cage suitable for us? Or more factors over there? though it's a westernized countries, in our country, most of the factors applicable to us in this stage, small family size. Intestinal microflora stable because high antibiotic use. We don't expose too much of infections now, right? So here, we are actually in our country, our population having a higher risk of getting allergic disorder, even though genetic predisposition is not much there when compared to developed world. Now I will move over, given this background story of allergy and the non-allergy, I will move over to recurrent wheezing in preschool children. I actually wanted to touch this area, the preschool children wheezing is quite different for our asthma management protocols because it's a different entity. We need to recognize so many important things on managing a child, those who come to us in the preschool age. Is wheezing, it is a symptom, but not a disease. Why wheezing is so common in children? Their airway is narrow, they have a mucus obstruction is pretty easy, and cartilages are very soft and easily collapsible. So even it's not asthma, even any other condition, they can easily present to us with the symptom of wheezing. Not the disease of asthma, but the symptom of wheezing. Recurrent wheezing in preschool children can be associated with substantial morbidity and may impact on long-term health. So there is no doubt on that. Now, again, another important point to work out, the endotypes, if you are taking their bronchi and what is the constituents in their secretions. The preschool children, most of them, if you analyze the secretion inside while they are wheezing, they have a neutrophil predominance and the macrophages. But when you get the wheezing children with a wheezing who are school going age, if you analyze their mucus secretion, they are more or less eosinophil predominant. So that's very interesting observation that you can make on certain scientific evidence that you can gather this information. Neutrophil predominance in the preschool and eosinophil predominance in the school age children. Clinical recognition and phenotype of wheezing. And when somebody comes to us with a cough, cold, wheezing, plus or minus fever, we need to recognize whether this child likely to progress to asthma in future, or it's unlikely to progress to asthma in future, or it's very indeterminate. You can't predict. You need some more time to get the prediction. So these three aspects you need to think when the child, a preschool child, comes with wheezing. I just discussed with the first group. Who are the children unlikely to develop asthma? So these are not like 100% true factors, but the majority, these kind of presentations are applicable for majority. If somebody comes very early ages, like about 3-4 months, you all know that could be viral induced like a bronchiolitis. If the cough is a very productive kind of a wet cough, now you all know what kind of a cough these people would get. It's like not a very productive, and you get the high pitched sounds at the end, like I can't show you because I just recovered from a flu, like like so. At the end, you get the high pitched sound, the close in. So that, of course, with the bronchospasm. If somebody gives like a productive kind of a cough, what you usually hear with the bronchitis people or bronchiectatic type of a cough, you call it a wet cough. Very unlikely to be asthma. And if a child just associated with some other physical problems like a failure to thrive, finger clubbing, choking with feeding, and these sounds are not the polyphonic, it is very static and like a monophonic throughout the day, and you treat for asthma, but the response is poor, then you have a doubt whether we are dealing with the asthma or something else. So if these features are present, it's most of the time it is unlikely to develop over to asthma. So the differential diagnosis, so these unlikely to develop asthma could be in one of these groups. Airway instability could be tracheomalacia or bronchopulmonary dysplasia, and could be aspiration, could have been a gastroesophageal reflux disorder or any disorder with the swallowing functions, or could have been an obstruction with the lymph node mass or vascular ring, or could be the mucosal damage of frequent infections like a Carter-Gunner syndrome and cystic fibrosis or protracted bronchitis, right? And it could be bronchiolitis obliterans, and it could be chronic infections like a tuberculosis, aspergillus, or bronchiectatic type of a chronic infections. So these also can mimic the picture of asthma when a preschooler child comes with a wheezing, but this may not be the true asthma. So we need to find out this kind of a large list are there that mimics asthma conditions in the preschool child. So then second group, then when the child comes to us, we take a history, we examine the child, and then you probably should be able to predict, and this child will be able to be in future would progress over to asthma. Who are they? They have an atopy, giving a history of a dermatitis, giving a history of a food allergy, and if you do the skin testing and there is allergic sensitization. There is a family history of asthma. Parents having some kind of a allergic manifestation, or the siblings having the allergic manifestation. When you do the blood counts, it shows the increased eosinophil count in the blood counts. And when you treat for asthma, very rapid response to asthma treatment. Those are the crowd that's likely to progress over to asthma. What are the phenotypes? This Tucson study is a very famous study done in 1980 involving a lot of countries in the world. And they actually analyze the children, preschool children with wheeze. So they have three categories: transient wheezers, persistent wheezers, late onset wheezers. The transient wheezers, they commence before the age of 3 years and disappear by 6 years. So to be honest, we always come across this group, transient wheeze. But it's very difficult for us to label transient wheeze because it's quite difficult for us to diagnose them or pick up them as a transient wheeze. But by about 6 years, we know most of the parents will come and say, then none had any wheeze. So they are transient wheezers. Persistent wheezers, symptoms that are found to have continued until the age of more than 6 years. Late onset wheezers are they are the ones that who starts their wheezing after 3 years of age. European Respiratory Society classification. So this is the Tucson study, their classification. There are 3 groups they mention. And interesting, this is the ERS classification, European Respiratory Society. And how do they categorize these preschool wheezers? They say episodic wheeze or multi-trigger wheeze. Very interesting. Who are these episodic wheeze? They come with the wheeze with the cold or fever, and then they are completely free of symptoms the rest of the weeks or months, and then they get another episode. So like a discrete episodes, in between those episodes, they are quite symptoms free. Multiple trigger means multi-trigger ones, they are getting exacerbation, but they never free of those symptoms throughout every day, like every day they are having symptoms. So this is the majority, the parents will come and say, කවදාවත් කැස්සයි ඔටුයි හොඳ වෙන්නෙම නෑ බබාට. හැමදාම කැස්ස. බෙහෙත් ගන්නකොට ටිකක් අඩු වෙනවා. ආයි වැඩි වෙනවා. අඩු වෙනවා වැඩි වෙනවා. හැමදාම same. So that kind of a complaints that we are frequently getting from the parents' side. So these are just very clearly described, the episodic wheezers and the multiple triggers wheezers. When you actually explore the story or the histories from these children, you will be definitely able to categorize either they are episodic or multi-trigger wheeze. So this episodic multi-trigger, we are just comparing these two. Discrete episode, as I described you earlier, interval symptoms. Viral infections and fever, usually they have. Multi-trigger ones, usually they don't have a fever most of the time. In episodic wheeze, they are viral induced. So most of the time they have fever. Multi-triggers, they are usually the triggering factors is not the virus. It could be just an air allergen, cold, air, exercise. There are multiple triggering factors for this multi-trigger group. And well in between episodes, they are frequent and overlapping these symptoms. And these are seasonal. This is throughout the year. You call the word perennial. Now, this is again the Tucson study. And they analyzed the group of children. And year after they analyzed them again. Now, at the beginning of the study, there are like episodic wheezes. There are multi-trigger wheezes, right? Now, multi-triggers are 71, episodic wheezes are 38 in number at the start of the study. Now, year after they analyze and whether they are the same in the group or they have in a different group now. Now, what they realize, these episodic wheezes remains 22 as episodic, 13 children, no wheezes, completely disappear of the symptoms. And then out of these 38, 13 gone, move over to the multi-trigger type. So in contrast, the multi-trigger group and the multi-triggers ones move over to the episodic ones 22 and remains as a multi-trigger 38 and no symptoms in 11. So it's actually not static picture. It can be, it's actually a dynamic picture. When you at one stage you will be able to say this child is like an episodic visa, but 2 years later when you comes over to the diagnosis could have been moved over to some other category like a multi-trigger category. So this study nicely explain how they evolve these categories within time. Now, diagnosis of asthma. The asthma diagnosis, as this is the gene diagnostic method, asthma predictive index more than 4 episodes per year and they should have either one major or 2 minor, right? So how do they diagnose? You should have, somebody should have a 4 episodes per year plus 1 major. Either physician diagnose atopic dermatitis, physician diagnose parental asthma, allergic sensitization to at least 1 aero allergen. This is after your skin prick test. Or there should be at least 2 minor. Wheezing unrelated to colds, eosinophils more than 4%, allergic sensitization to milk, egg, or peanuts. So, asthma index more than 4 episodes per year having 1 plus major diagnosed of asthma. Or predictive index more than 4 episodes per year, no majors but having 2 minors, again you can diagnose asthma. Now, this is again a GINA guidelines and that shows again if some patients, when you elaborate the history and they have symptoms, cough, wheeze and breathlessness for less than 10 days during upper respiratory tract infection, they are getting 2 to 3 episodes every year but no symptoms between episodes. So you categorize it episodic or discrete symptoms. If you get that kind of a bunch of patients, they are in that particular group, very few have asthma, right? Now, the second group, they have symptoms, cough, wheeze and heavy breath for more than 10 days during upper respiratory tract infection, more than 3 episodes per year or severe episodes and or night worsening symptoms. Between episode, child may have occasional symptoms of cough, wheeze or breathlessness. Not here, very few have asthma, but in this group, some have more than this, right? Now in this third group, symptoms of cough, wheeze and heavy breathing more than 10 days during upper respiratory tract infection, more than 3 episodes per year. Between episode, child is still symptomatic, and allergic sensitization, atopic dermatitis, food allergy or family history of asthma is there. This group of a patient, most of them are having this. So just see your history, your examinations are quite important for you to predict the future outcome of this patient. To be honest, for you to judge your preventive therapy, or just to when the parents, you might ask some questions whether my child is going to be a visa in future, whether you are going to recommend some preventive medicine for my child. So that kind of a things quite easily analyzed and come into a conclusion by looking at these factors or information in the history and in the examination. Now the third group, we talk about those who likely to go to asthma, those who are unlikely to go to asthma, and the indeterminate group, recurrent episodes of noise, breath, wheeze, viral infections every time, wet cough, fever. A lot of patients succumbs like this to us. Common cold, we say, kassa hembirisawa, right? And whenever they go to preschool, acquire some infection, comes to the doctor, settle, comes again and getting again and again. So that is a group, indeterminate group. I know it's quite hard for us to keep a boundary of these three groups, but first two groups are quite clear, we can keep a boundary there. But with this indeterminate group, it's quite hard for us to keep a boundary line. The management plan. I'm not going to discuss the management aspects in this lecture today. And you all know it should be personalized management plan. And it's just need to cater the individual person. And it has to be effective and safe. And for that particular child to just go on a normal life as much as possible. What do you mean by the normal life? They should be able to eat freely. They should be able to have a bath freely. They should be able to go to school, learn, play, and all her childhood activities should be able to entertain. Otherwise, no use of just having the management plan. So our aim has to be just give a normal life for our child. Parents la hota ice cream ekak kanna puluwan. So that's again, I would say yes, right? Because they should entertain whatever they like to eat and drink. Right. Now I will move over to asthma in school going children. Now there are different phenotypes. This is real asthma now. That's preschool visas. I know it's quite hard to understand for our policy. That's why I wanted to highlight or elaborate much on the preschool visa. Now I'll move over to my other topic, asthma in school going children. Now allergic asthma, it's a childhood onset, past or family history of atopic, eosinophilic inflammation. I told you eosinophil, preschool and neutrophil respond well to ICS. So allergic asthma. If somebody well responded to our inhaled corticosteroids, right, that is nothing else. They are allergic asthma. That's why they are pretty well answering to our inhaled corticosteroid. Right? And those who are having a family history, past history, and childhood onset, typical picture, don't ever be late to start inhaled corticosteroid. Your first choice has to be inhaled corticosteroid. They respond pretty well. Non-allergic asthma, that is neutrophil accumulation. Let's respond to ICS. Right? They are hopefully not the allergic type. Very minor group in our people, in our children. We have a mainly the allergic group. Non-allergics are very few. Late onset asthma is adult asthma, especially in women. Non-allergic type, they require high dose of inhaled corticosteroid. And asthma with persistent airflow limitation. They are the patient with long-standing asthma, irreversible airflow limitation due to airway remodeling. Hopefully, this is just a very, very difficult group. and who were refractory to our treatment or hopefully not had a very good compliance or drug adherence, getting frequent episodes and the remodeling of the airway, and had the permanent disability or a chronic lung disease. They are called asthma with the persistent airflow limitation. Asthma with obesity, again, they are little eosinophils are there. Now, making a diagnosis, these are the factors which make us to move over to the asthma part. They have a wheeze, they have a cough, they are breathless. They say, my child's symptoms worse at night and varying over time in intensity. Early morning, child cough, but the daytime, 10 o'clock, 12 o'clock, he is wonderful. He does not have any symptoms. And most of the time, they easily catch up infections. And when they go to some other places, dust environment or cold environment or smoke, they easily get these symptoms, right? So triggering factors are identified. So these are increased probability of asthma, isolated cough, chronic production of sputum, shortness of breath associated with the other symptoms like a dizzy, lightheadedness, tingling, and or any other features. So that hopefully decrease probability of asthma. Asthma is usually a clinical diagnosis. You might need investigations to rule out if you have any doubt about your diagnosis, or whether just to find out whether there are any other comorbid factors for this. Otherwise, asthma pretty much easy to diagnose. Clinical diagnosis is needed, right? And other investigations are less supportive. But one important thing is our spirometry, peak expiratory flow rate, and those are the two tools that are really needed to confirm the diagnosis of asthma. So the medication I will just go through quickly. The controller medication, you all know, reliever medication. And the controller medications are just giving the permanent relief for us. And it reduces the airway inflammation and controls symptoms and reduces the future risk. Reliever medication are the short-term patch. And they are just whenever the child requires it as needed. We just give to just whenever the child gets a breakthrough symptoms, just to prevent them going into an exacerbation, we use reliever. Don't ever ask the children to get the reliever medication when the cough gets worse or when you witness the breathlessness. No, that is wrong. Whenever the child experiences the first symptom of cough, you should start a reliever with a low amount of puffers, right? So what is our aim is to prevent them moving over to a higher level, right? If it is a mild asthma, we should not move over them to a moderate. If they are moderate, we should not allow them to move over to the acute severe. If they are in acute severe, we should prevent them moving over to life-threatening. So the reliever medication you start whenever the child shows mild symptoms, right? So eliminating the need for SABA reliever is an important goal in asthma management. If a child comes to you while on inhaler, mother said, I frequently use my SABA. So that means the child is not under control. If somebody says, last 6 months I did not use SABA at all, I just used the controller medication, that child is very well controlled. So the need for SABA reliever is an important goal. Eliminating the need of a SABA means pretty well controlled child. And you have add-on therapy and persistent symptom with high dose controller medication. Leukotriene modifiers are there, Montelukast, Pranlukast, Saprolukast, Sileuten. So these are the Montelukast are the ones that are quite familiar to us. They are the leukotriene receptor antagonists. So they are anti-leukotrienes. They are now here the leukotrienes are there in the normal quantity, but they cannot act on the target organ because leukotriene receptor antagonist, the Montelukast. But when it comes to Sileuten, That means you are actually preventing the formation of a Montelukast that is not available in our country. So preventing the formation of the leukotrienes is Silotan, and preventing the act of the leukotrienes over the receptor organs is the Montelukast, right? Hormones are there and they are hopefully not much in use nowadays. What are the reliever medications? Now I just moving over to a little bit towards the new GINA perspectives. Now we have a SABA, short-acting beta agonist. We have a salbutamol puffers. We have a terbutaline puffers, not in our country. And low-dose inhaled steroid plus a formoterol combination. We never use these as a reliever medication for our children, but now these low-dose inhaled corticosteroid plus a formoterol, we have a budesonide formoterol combination in our country. Beclomethasone formoterol combination we don't have in our country. So these two puffers they use as a reliever medication, not for children but for adults. Right? But when the time comes, we will see what happens to the children's management. And then we have a short-acting anticholinergies, LAMA, not LABA, ipratropium bromide or oxytropium bromide. That is again now becoming very popular. And those who are not relieving with the SABA, and when they are getting the breakthrough infection, some physicians, some pediatrician, now the trend is to move over to another add-on reliever medication that is LAMA, short-acting anticholinergies. Right? Controller medications, you know, inhaled corticosteroid. We have a group of inhaled corticosteroids popular in our country. Beclomethasone dipropionate, budesonide, fluticasone, cyclosonide, fluticasone, triamcinolone, and I'm sure the mometasone is now they are trying to establish mometasone also inhaled corticosteroid. And then ICS and the LABA combinations, beclomethasone formoterol, budesonide formoterol, fluticasone formoterol, fluticasone salmeterol. So these are a lot of combinations are there, and some of the combinations are not available in our country. Add-on therapy. Now the GINA recognized azithromycin 3 times per week for 6 months. Those who are resistant, right? Omalizumab, anti-IgE therapy for moderate to severe allergic asthma. Mepolizumab, anti-interleukin 5 and severe eosinophilic asthma. Benralizumab, anti-IL-5 receptors, and subcutaneous immunotherapy and sublingual immunotherapy, adults asthma and allergic rhinitis. So these SCIT kit and the slit, and so these ones are hopefully not very popular still in our country, because I think because of the cost, other countries they are very severe resistant cases. They use these like a biologics, these drugs they use now, still not popular in our country, I'm sure, because of the cost. But skid slip, they are not very expensive though, but yet to come to our country. And now most countries like German, America, UK and India, very popular, the skid and the slit for the resistant cases, especially not with the asthma, even the resistant allergic rhinitis, and they use skid and the slit and giving a promising result. Just a complete cure. We never talk about the cure of asthma or allergic rhinitis in the past, but with time, it's yet to come, we can talk about the complete cure of allergic rhinitis and asthma by way of doing this immunotherapy. That is a kind of a desensitization, subcutaneous and sublingual immunotherapy. Now, this is a GINA. And now how do you get the well-controlled, partly controlled and the uncontrolled? You need to, every day in the clinic, you have to get 4 questions. Daytime asthma symptoms for more than a few minutes, yes or no? Any activity limitation? Yes or no? Reliever medication needed more than once a week? Yes or no? Any nighttime symptom? Yes or no? None, well control. One or two you pick as yes, partly control. Three or four you pick as yes, uncontrolled. So this is the easy method you recognize your child is well controlled, partly controlled or uncontrolled. And the lung function test, the spirometry. Persistent low force expiratory volume in 1 second predict asthma. Normal or near normal force expiratory volume 1 unlikely to be asthma. Persistent bronchodilator reversibility. Now you get the spirometer results, you get a certain value for your FEV1 and you give the bronchodilator therapy and you reassess your FEV1. If it has improved more than 12% or 200 ml from baseline indicates case and it's an uncontrolled asthma, right? And persistent bronchodilator reversibility. FEV1 is just, if it is, sorry, I got a little stuck here. Persistent bronchodilator reversibility is there. Yes, so it's a reversibility is there. So now it means you give the puffer and you give the bronchodilator therapy, and if it is changes from more than 12% and the volume changes more than 200 ml, that means you have a reversible airway disease. That is a way of diagnosis of asthma. Asthma action plan, child's usual asthma medication, when and how to increase medication, and how to start oral corticosteroid, how to access medical care if symptoms fail to respond, and it's very important to have an asthma action plan. Key changes in GINA. I will just go quickly now. I have already talked about these things. Treatment of asthma with SABA alone no longer recommended for adults and adolescents. Not for us, adults and adolescents. Reason? SABA only treatment increases the risk of exacerbation, and that adding any inhaled corticosteroid significantly reduces the risk. So the adults, when they get the symptom, they keep on getting this short-acting beta agonist, and so they recognize some people has used more than 4 or 5 canisters every year, and that hopefully giving the bad results for adults. And I don't think in children we use that kind of a liberty to parents to use SABA. They use with cautious, very cautiously, and little amount they use, but the adults they have used freely, and ultimately what they have recognized the bad results: beta receptor downregulation, decreased bronchoprotection, rebound hyperresponsiveness, decreased bronchodilator response, increased allergic response, increased eosinophilic airway inflammation. So now new GINA guidelines, adults no SABA as a reliever medication. They use ICS plus formoterol as the reliever medication. I will come in shortly for that particular point. But preferred reliever therapy for step 1 to 5 in 6 to 11 years old, still SABA. More than 12 years, you call them adolescents. That could be similar to adult. First choice, as needed, ICS plus formoterol. Second choice could be SABA. I think it is clear to you all. Adult SABA no longer use. Rare occasions still they use, but they recommend ICS plus formoterol as a reliever. And more than 12 years or older, still optional. Either you can use like an adult, like an inhaled stick corticosteroid plus a formoterol, or still you can go for a SABA, that is adolescent. And 6 to 11 years, because we used to this particular age group, but still our policy is not changing. We use SABA as the reliever. Right. Now I'll come to this adults and the 12 years plus. And so you can see step 1, as needed low dose ICS formoterol combination here, right? And So the preferred controller method is also preferred controller is a low dose ICS plus a formoterol. Preferred reliever is also a low dose ICS formoterol. So they are just getting the same canister for a preventer as well as the reliever, right? But other reliever option, they kept another last line as needed short acting beta 2 agonist you can use. So in that case, who are they? Just in case sometimes if somebody use this preferred controller method, not the ICS format or something else, like say salmeterol plus a fluticasone, in those cases, they can use this SABA. So if somebody use ICS formoterol as a controller method, they use reliever the same, right? Now you call it MART or SMART, single maintenance and reliever therapy. SMART or MART, both words are used. Single maintenance and reliever therapy. So formoterol ICS controller, formoterol ICS reliever. When it should not be used, ICS formoterol should not be used as the reliever in patient prescribed different ICS LABA as the control. As I say, if somebody use Seroflow or Serotide here, then they have to use SABA here. Right? Based on product information, I have a little doubt on this. I just went through the product information and the format, like a, what you call the for a code, formoterol plus the budesonide combination. They say single day is the total of 72 microgram you can use. Maximum yanna puluwan 72 microgram. One puffer contains 6 microgram of formoterol. So in that case, even with a severe exacerbation, the adult, they have to use within that particular range 12. Mama danne, this is a GINA guideline. Say, I don't know how the adult patient they manage. So they have to just take this ICS formoterol or a Foracort combination. They can use 72 microgram maximum every 24 hours. This is children 6 to 11 years. Just see, we take a low dose ICS taken whenever SABA taken. So we have a SABA still as a reliever. We have a controller with the inhaled corticosteroid. So no change in our policy, 6 to 11 years. Children 5 years and younger, and still we have no change in our policy. Right. After starting inhaled corticosteroid, you need to review response after 3 months or according to the clinical urgency. If the control is poor, you need to think of step-up treatment. But whether you are going to step up or for a sustained setup, that means you just go for a longer period like a 2 or 3 months, or you are going for a short period like a temporary step up, that is whenever the child gets a cough and cold, that particular period you give puffers number, high number, you have to decide. So sustained step, if you want to move over to a sustained step up of your treatment, if somebody on the second level, you want to move over to the third level, before moving over to the third or a higher level, assess the following common issues before stepping down. Incorrect inhaler technique, poor adherence, modifiable risk factors, comorbid condition. And short-term step up by clinician or by patient with written asthma plan during viral infection. Those who were on a beclomethasone 100, 1 puff BD, we ask them to go for a 2 puff whenever your child catch a virus, right? So that is a short-term step up. If the asthma is well controlled, step down treatment and find the lowest treatment that controls more symptom and exacerbations and choose appropriate time for step down. Choose appropriate time for step down. Very important key figure here. Why? Now, like these days in Sri Lanka, when we have a lot of patients comes with a viral infection. infection and asthma exacerbation, even though child was under control for more than 3 months, well controlled for 3 months, we should not think of stepping down treatment because they can exacerbate quite easily. That's why you say choose appropriate time for step down, right? One important point, exercise-induced asthma, exercise-induced bronchoconstriction. Those are the two new terms given in the GINA. Very interesting to understand these two. Exercise-induced asthma means the child who has a background history of asthma triggers bronchoconstriction with the exercise. Exercise-induced bronchoconstriction, child never experience of asthma, no diagnosis of asthma, but the exercise is the only trigger for bronchoconstriction. And role of immunotherapy. Allergen immunotherapy cannot be presently recommended as single therapy when asthma is the sole manifestation of respiratory allergy. GINA 2022 recommends adding house dust mite slit in adults and adolescent asthmatics more than 12 years with allergic rhinitis and FEV1 less than 70% from step 3 onwards. Very important key figure here, and I just wanted to highlight that because if somebody comes with the house dust mite is the main triggering factor for asthma and the allergic rhinitis, and those somebody having these asthma and allergic rhinitis both, and house dust mite is the culprit, and they are hopefully good for a slit therapy, sublingual immunotherapy, and so they hopefully they recommend so they just move over to slit. Now that's why I told you the GINA guidelines, we all follow GINA. It is important to download the new GINA guidelines and you have to read it as registrars, and I always ask the medical students to do it and update themselves because it's just changing time to time with the evidence base they acquire, they receive, and so it's quite interesting. Now the adult management has the dramatic change and the children's management also. Just we are actually just doing a little changes over to this. So with time, I am sure these ones comes into our management protocols. Right. So hope that I finish my lecture nearly in 1 hour. Right. So that's all I have to tell about this preschool wheezing and this wheezing school going children and the GINA perspectives, new changes. Right. Thank you so much for listening to my lecture.